name is Nick Pamilya. I'm one of the new IM faculty here. And I'm going to be introducing Tracy Rabin. She's our speaker today for the Global Health Grand Rounds series. The title of her health is Global Health is Local Health Resident Education Beyond the Clinic Walls. So I've known Tracy for several years now. We started working together at Yale when I was a resident, and she first as a attending when I was a resident and mentor, and now we collaborate together on a project I'm involved in Grundy County. We're involved in Grundy County. She's an assistant professor of medicine and associate director of the Office of Global Health in the Department of Internal Medicine at the Yale School of Medicine, associate director for global and community health in the Yale Primary Care Internal Medicine Residency Program. Since 2011, she's also served as the Yale co-director of the McCarry University, Yale University, or MUU, collaboration, which is a bidirectional medical education capacity building collaboration based at the McCarry University College of Health Sciences, Mulago National Referral Hospital in Kampala, Uganda. She also attends and teaches mostly at the St. Raphael's campus, which is where our primary care program at Yale is located, directs the Yale Primary Care Community Engagement Curriculum, directs the home visit elective, and is the founding co-director of the Global Health Ethics Program at the Yale Institute for Global Health. She focused both local and international opportunities to support medical trainees who are interested in global health-related issues, and she's the founding director of the Global Health and Equity Distinction Pathway at the Yale Department of Internal Medicine. Her current scholarship focuses on the care of vulnerable populations, both domestically and internationally, ranging from interprofessional global health, workforce education, and equitable, ethical global health partnerships, community engagement, and physician advocacy during training, and outpatient management of diabetes. So it's my pleasure and honor to have her here and to be able to introduce her to all of you. She's really been instrumental in my fledgling career, and thank you all for being here today.
Thanks so much, Nick. It truly is a pleasure to be here, and you guys basically have already seen most of my grand rounds at this point. The slides are, so, oh, back too far. Okay, we'll see how our technical situation plays out, but it is a pleasure to be here with you today. Can I just so I get a sense of my audience, can you just raise your hand if you are a student sitting in the audience? Wonderful. Okay, students are over there. What about residents? Excellent. Okay, great. And then faculty? Okay, and anybody else that I didn't identify who's in the audience? Yes?
Just someone from the community interested in your topic.
Wonderful. Okay, great. This gives me a sense of who's here. I am a clinician educator. Nobody wants to pay us to do that, so I have no financial interest to disclose. So as far as our learning objectives for this morning, I've sort of broken this talk into two parts. The first part is to talk sort of more generally about the benefits and challenges of global health clinical training opportunities for medical residents. And a lot of it certainly is transferable to students as well, but I'm focusing mainly on residents because that's the bulk of my experience. For the second part of my talk, I'm going to sort of walk you through three specific examples that kind of look at how global health clinical training has evolved over time at Yale, looking at some of our international partnerships, looking at an effort within our primary care residency program, and then finally finishing up to talk about what we've been working on here in Tennessee. So to start off, because this is the first time that I'm meeting all of you, I realize that Grand Rounds is not usually an interactive situation, but it would be really nice if somebody could just raise their hand and let me know, when I say global health, what does that mean to you? What does it make you think of? Everybody came here to hear a talk about global health this morning, so what were you thinking we were going to talk about? I have tremendous capacity to wait, so. Health equity. Okay, great. Thank you. Anybody else?
I feel like in global health, we always say that it's parallel to rural health care, but I think a lot of us don't make that transition. So I'm looking forward to hearing how that transition can actually be made.
Fantastic. Wonderful. Thank you for sharing that. Any other thoughts? Yes.
I think of it as culture entry models. So in a sense, you have to have some capacity to enter into a culture, whether that one is the distance of
Mm-hmm. Absolutely, yes. So thinking about sort of cultural and sort of a cultural humility model, so having had the capacity to enter into another culture, but sort of being open to the idea that you're going to be learning things, that you're not necessarily bringing a culture that is superior in any sort of way. And you had your hand up too.
Health transcending national boundaries.
I love it. I love it. Thank you. It's almost as if you've already seen my next slide. So I love what I'm hearing here, and I think a lot of the things that have been brought up play into this definition of global health, which this is a formal definition that has been put forward through the Consortium of Universities for Global Health, and I'll tell you more about them in a second. But essentially, the definition here states that global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. So knowing no geographic boundaries here. Global health emphasizes transnational health issues, right? We're all connected. Determinants and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration. And then finally, this is a synthesis of population-based prevention and individual-level clinical care. So it's a mouthful, but this definition was sort of put forward by so this consortium of academics from all over the world who came together in the late 2008-ish to say, well, what are we talking about when we say global health? Because a lot of people at the time were saying, oh, global health is something that happens out there, especially if you're coming from the United States or Western Europe. Global health is out there, but really this emphasizes the fact that, global health is all of us, and as it turns out, the United States is on the globe. The article that this was published in truly is a seminal piece in global health. So for those of you who are interested in taking a look at it, this QR code should link you directly to the article. So if you just aim your camera for your smartphone, you can pull it up, and the reference is here. Okay, so now, but I'm here to talk about global health clinical education. And so what do I mean by that? So there are a couple of pieces that I think comprise global health clinical education. So the first is that you're thinking about a clinical setting that is other than your typical training environment. And again, we're talking about residents, but other than your typical practice environment. So something that's going to take you out of your sort of everyday. If it's possible, it's wonderful to think about how this could be an immersive situation for this training experience, because there is something that is so valuable about being away from your normal and finding yourself in the community where your patients are living. It sort of forces you to think more broadly about what their lives are like, and to actually be more curious about what's going on in their lives that's going to impact their health. And then the third sort of major component is that the relationship with the place where this care is happening, where this clinical work is happening, should include some form of capacity building or capacity strengthening aspect. So this is not just like when we send our residents to do a primary care rotation for a month with a community partner in New Haven. That's a wonderful learning experience, but I wouldn't characterize that as a global health clinical experience. There's not really a two-way street there. There's no capacity building. The resident is the one who's directly benefiting from that exchange. As with all of our endeavors, the goal should be improvement in the care of patients, but also global health clinical electives think about the health of the community as well. And this gets back to that important part of the definition that I highlighted earlier, this priority on improving health and thinking about how to achieve equity in health for all people worldwide. Okay, so I'm biased towards the benefits. I'm going to start talking about the benefits. And I'm going to look at this from a couple of different perspectives, from the perspective of the training program and the health system, from the perspective of the patients, and then the perspective of the trainees. And then we'll get to the challenges later. Okay, so some colleagues in pediatrics published a wonderful resource for program directors who are interested in thinking about global health education. So the bullets that I'm going to put up here are taken from that paper. There certainly are many other benefits to talk about, but I thought they had a really nice, succinct way of putting it. So the first that they mentioned was that diseases do not respect borders. I mean, I think you pick up any paper today, we hear all about COVID-19. This is sort of one example of many, many examples. And so having an opportunity to do some sort of global health clinical experience not only might allow you to see new diseases that you don't typically see in your clinic, but you might in the future, but also allows you to see different presentations of the same illnesses that you're used to treating. So you might see a late-stage presentation of something that you don't typically see, or a different presentation from a different population. Certainly, having trainees and having physicians who have this breadth of experience is something that is of value to the training programs and also to health systems as well. So second, as we all know, resource limitation, although we talk about it sort of as being out there often, is not limited, it's not unique to low and middle income countries. And certainly, we are aware of the tremendous health disparities here in the United States within this very state. So having an opportunity as a trainee to be in a different setting where sort of these resource limitations are often much more vivid because they're not part of your everyday, helps you to see sort of what are some of the creative ways that local providers may have tried to address these resource limitations, and these are things that we can bring back to apply to our own health systems, but also just having a broader sense of how to navigate limitations. And then there are a number of skills, these are just a few, but a number of skills that are relevant to caring for patients who are from diverse settings, but also going to diverse settings, thinking about those folks who are going back and forth. So, one highlight would be how to use interpreters effectively. And certainly language interpreters is one piece, but also even cultural interpreters, being in a new place and how do I talk to people about, these health habits, or what do they mean when they say this? I'm hearing this issue over and over again, but I don't know that I understand it in the same way that they mean it. Caring for immigrants and travelers, certainly this is an important piece. Employing cultural humility, so this gets to sort of what Mike was talking about before. And then really thinking about how to integrate social determinants of health into your clinical paradigm. Again, there is something about being in a different community and being immersed in a different community that really brings sort of these social determinants of health into sharper relief often than the typical day-to-day. Now, from the patient perspective, there are concerns that are universal. And I can, having worked clinically in Uganda for years, having worked now clinically in Connecticut for years, I can attest to the fact that the skills that I use in caring for patients in both places are very similar. The nuances of the situations may be different, but the skills are the same. This map here, does anybody have a sense of what this map might be? That's right, COVID-19. So this was yesterday. This is where COVID-19 has been reported. So thinking about the universality of the concerns that people in all of these green highlighted countries are sharing just related to this one illness. But the things that I wanted to bring up for you today are things like access to care, access to medications, thinking about why it is that I'll tell you a bit about our collaboration in Grundy County a little later in my talk, but we're working at a clinic that is free to patients. These are patients who otherwise would not have access to care. In general, they don't have insurance. And so they have, so this is the clinic that they're able to go to for care, but certainly that's a worry. And if that clinic were not there, what would happen to these folks? Health literacy, certainly this is a concern both here and anywhere in the world. You need to be able to ensure as you're telling your patients, this is the advice that I would give you, that they actually have the capacity to understand that and understand why it's important to them. Worries about whether their race, their ethnicity, their class might impact the care that they're receiving. Certainly that's a universal concern that I see, as well as stigma, disease-related stigma, and how does that impact care. Patients certainly have competing priorities. You're telling me that I need to be taking, insulin glargine once a day and then additional insulin 3 times a day, and that's what you tell me I need to do. It's really expensive. I need to make sure that my family can eat. I need to put gas in the car so I can go to work. So I don't know that I'm going to be able to do all of that. So how do patients weigh these things? And then finally, trust in the healthcare system. We see this here. This is something we see everywhere, and really, when you're in a different setting than your typical practice, it forces you to think about, well, how am I going to get this patient that I'm seeing to trust me? I'm somebody coming from outside. It really forces you to hone those skills. Okay, so this was just something, as I was putting this talk together, it's just something that I was considering. So thinking about a year in the life of a patient. So I was being generous. So perhaps a patient spends 120 minutes with their doctor in a year. So that was sort of, if you have a 15-minute checkup every 3 months, and then maybe you've got 4 urgent visits over a year. So 120 minutes a year. And you divide that by 525,600 minutes. And apologies to anyone who has seen Rent, the Broadway musical. Now you're going to have the song Seasons of Love in your head all day. But so what this boils down to is the fact that patients spend 99.98% of their year outside of the clinic. And when I think about it that way, I think about how amazing it is that patients do really anything that I say, right? So I'm giving them advice based on my 120 minutes with them. And based on that, they're making changes to their lifestyles that are improving their health outcomes. It really is incredible to me, and based on a very limited perspective that I have about what's happening during that larger part of the year. So, and the reason I bring this up is because I think there is something about being in a different community and working with a different population that often sort of highlights how little it is that we know about our patients and reawakens that curiosity that we have that actually translates back to your typical practice. Okay, so benefits from the trainee perspective. So this is the last piece. And this is you know, these are general thoughts that come from the literature. When people interview trainees who have gone on sort of away rotations and come back, you know, what are the benefits that you bring back? You know, improved medical knowledge, certainly about different conditions, experience navigating resource limitations, as I mentioned before, you know, improved cultural and interpersonal competence. This is sort of a big highlight, and social determinants of health. But I think this last bullet point I have yet to see in the literature. I have been trying to figure out how to study this for years. I have not figured it out. But I can tell you that uniformly, whether it's taking residents on home visits in New Haven or debriefing them after a 6-week rotation in Uganda, when people come back from having these experiences, they say, you know, this was such a breath of fresh air. I remember why I wanted to be a doctor in the first place. This gave me an opportunity to think about why I'm in medicine. And, you know, we think a lot about burnout and wellness. And, it's, you know, I've even had people say, you know, I was feeling burnt out, and then I went on my elective, and now I'm coming back, and I don't feel burnt out anymore. And I don't know how to capture that. So I'm sorry this isn't the evidence-based portion of my talk. But I think it is something that needs to be recognized. Okay, so I said I would talk about a couple of challenges because it's not all just sunshine and rainbows. But so certainly logistics. Right, so residents having the time to work outside of their typical clinical setting is tricky, and there's a cost associated with that. If they're off-site and you're paying their salary while they're away, so certainly that's an added cost. And if you need to bring on additional trainees or if you need to bring on additional providers to help to fill that void, that certainly is a cost as well. And then there are also administrative barriers that are related to collaborating with other sites, and you know, those are fairly easy to overcome, but they exist. Certainly there are also clinical coverage needs, and this kind of gets back to the cost piece, meaning, you know, you have a full set of residents in your program, and so, you know, if somebody's out for family leave or somebody's out for vacation, you know, usually you have enough flexibility in your resident pool to cover that. But then once you start having other people that are off-site, then you need to really think about, do we have a deep enough bench to be able to have people cover what we need to cover in the hospital, but still provide for these experiences. There also may be limited resources for faculty to develop these programs, for your institution to have partnerships with other institutions outside of sort of the typical, and also curricular resources. So certainly, you know, that is an important piece to consider. And then lastly, but certainly not least, are health and safety risks that may exist for learners who are going and working in other places. And I'm thinking about a resident who, you know, 2 months ago had a needle stick injury in Uganda. And if our partnership were not as robust as it is, and if I did not have the full trust in my colleagues there, it would be a lot harder to manage the anxiety of that resident. But the fact that, you know, we work together, we've been doing this for years, I know their processes, and I know that they are going to be able to do what he needed in the same way that we would do what's needed for their trainees. It makes me sleep easier at night sending our trainees out to do that kind of work. Okay. So then there's the question of how to engage in global health clinical education. And so Nick mentioned that one piece of what I do has to do with global health ethics. So this is another audience question again. So when I say ethics and medicine, are there any principles that come to mind that people think of?
First, do no harm.
Excellent. First, do no harm, right? Okay. Anything else? Yes?
Justice, how do you make it equitable?
Absolutely. So justice. A lot of people talk about autonomy as being the principle that sometimes supersedes all other principles in decision making. So these are the typical sort of ethical principles that we use in medicine. And you know, it's interesting. So when you think about applying these principles to a global health setting, there actually are a lot of criticisms, many of them stemming from the fact that those sort of main principles come out of a very sort of Western philosophical religious background and are not necessarily as applicable. So what I'd like to do is propose sort of 4 alternative principles that institutions can use when they're thinking about sort of how to engage with partners in other places. And I did not develop these myself. These came from colleagues at University of Toronto. They were originally developed to help trainees thinking about global health engagement. And then colleagues at Yale and in Uganda and I came together and said, you know, actually these can be applied on more of an institutional level as well. So the first would be humility and sort of recognition of one's limitations. You know, when I think about, you know, Yale being involved in places, you know, we are not Doctors Without Borders. You know, I cannot say that to my colleagues in Uganda, I'm going to come and I'm going to be able to provide care better than you can because you know your population, you know your resources. I can't just send residents in and have them take over the medical service, right? I have to be humble and realize what I can and cannot do. But what we are is an educational institution, right? So I can send residents there to partner with your residents and they can teach each other, they can learn from each other, and we can set up programs that are going to help to improve patient care through educational exchange. The second is introspection and really thinking about why it is that you're getting involved in whatever this partnership might be. And importantly, telling your partners why it is that you're getting involved, right? You know, for us to be able to say, well, we're looking for a place for our residents to have a specific type of experience, and this sounds, you know, like it would work, it's important for our partners to know that that's part of the motive. We have to be honest about that. And I also expect that my partners are going to share with me, well, what's the benefit to them of having Yale involved with their site? And also I expect that we are going to be reevaluating that on a continuous basis to make sure that, that both sides are satisfied in a relationship. The third is solidarity and ensuring that your goals in being in a particular place are aligned with that of the community that's being served, right? The idea is not to go in and say we are going to not only take things over, we're going to change it completely because this is how you do it better, but really to think about, well, what is the community hoping to get out of this relationship? Where are they hoping to go and develop? And ensuring that you are supporting that work. And then the last is social justice. So thinking about what are the inequities that currently exist? What is the system like for the partner that you're going to be working with? And how can you work with them to try to address some of these inequities? So these are sort of the 4 principles that I like to promote in terms of global health partnerships. Okay, so that's the end of the first part of my talk. So I'm going to pause there for a second. Thought this was a nice picture. Okay, so now I'm going to switch into giving you some examples. As I mentioned, I'm going to talk about 3 different examples of global health clinical education that we've been doing at Yale. And the first is focused really on our international partnerships and bidirectional capacity building. So Yale has been sending residents abroad to do clinical electives since 1981. We're actually the oldest program in the country to be doing that. And this program was initially started by these 2 colleagues, Frank Villa, who's an infectious disease doctor at Yale, and Michelle Berry, who is now gone on to Stanford, where she's their vice dean for global health. And from 1981 to 2001, they were sort of in charge of what we used to call our international health elective program. And under this program, there were, I think at one point there may have been 25 different sites. Residents could get funding to go and do a 6-week rotation at the sites, have a fantastic experience, and come back. But unfortunately, there wasn't really much that was being left behind for the partners. There really wasn't this sort of bilateral exchange. So something happened in 2001, which was that we were able to get funding from the charitable arm of Johnson & Johnson, which allowed us to focus in on a smaller number of sites and really think about sort of this collaborative model and more of a bidirectional model. And my colleague Oskar Rastegar, who's now our director of the Office of Global Health, came on board in 2009, leading what we now refer to as our Global Health Scholars Program. So it was really this sort of switch from sort of a resident-focused experience to really thinking about a capacity-building model for both residents as well as partners. So now, we call ourselves the Yale-Stanford J&J Global Health Scholars Program, and the goal of this program is to inspire a more global vision of healthcare among residents in our internal medicine and combined internal medicine pediatrics residency programs. So for those residents who came into residency and said, I am passionate about global health, I want to do this as part of my training, this is certainly perfect for them. But we actually feel that the perspective that you can gain from having these types of immersive rotations is so important that we try to make this as easy as possible for folks who never thought they would spend any time outside of the country during training. We want them to take advantage of this too. So when our chief residents are preparing the schedules for the year, the first thing that goes on the schedules is who's going where and when are they going, and then all the other schedules are sort of built around that because we don't want people to have to fudge their vacation or do other things. We really want people to take advantage of these opportunities. So since 2001, we've sent over 1,000, we have had over 1,000 sort of resident, fellow, and faculty rotations, and that actually is only 951 individuals, as my administrative colleagues remind me, because some people did it twice. That's a lot of people, not all from Yale and Stanford. We do also have folks who have come from other institutions to take advantage of the program. And we send folks on 6-week rotations. And so for the program directors in the room who are aware that there's an ACGME requirement that you cannot be away from your continuity clinic for more than 4 weeks at a time, just know that, because we felt that having this extended period was so important, we actually sought and were given sort of special dispensation from the ACGME. We said, this is the value of this type of experience. We feel this is so educational that we really want our folks to be able to spend 6 weeks away, because by the time you get to a place, get over your jet lag, and your colleagues there start to trust you, 4 weeks sometimes feels like you just are getting your feet under you, and then it's time to come back. And we do send primarily our senior residents because we want to make sure that our trainees are as prepared as possible to contribute wherever they're going. And importantly, as I was mentioning, we are a medical education institution, right? So our goal is to have our trainees partner with trainees that are local to the site so that they can learn from and teach each other. We don't, our goal is to not have people go in and take over care in a system that they've never worked in before. So just to give you a sense of where we're working, we have 5 sites right now. So the first to mention is in Kigali, Rwanda, where we partner with the National Hospital as well as a private hospital, a tertiary care institution, and a national medical school. This one is in Borneo, Indonesia. It is this primary care clinic that is literally plunked down in the middle of the rainforest. And this is such an inspiring place for our residents to work because the model here is such that if the surrounding communities sign on to an agreement to not engage in illegal logging, which is a major issue in the rainforest, and if they take advantage of the job retraining programs that the program offers, then they receive free health care at the clinic. And this has actually made such an impact on reducing illegal logging that they're actually looking to replicate this in another site. So it's a very inspiring place for residents to go and think about sort of the interaction between planetary health, between climate change and health and human health. Our third site is in rural South Africa. This is a picture from the hospital, but most of our folks are working in the outpatient clinic. So this grew out of an HIV-TB research collaboration that some colleagues at Yale had in rural South Africa. And so our residents mainly work in the outpatient antiretroviral clinic, but they also engage with the community health workers and do home visits, and they can do some inpatient stuff as well. Our fourth site is in Cali, Colombia, and again, here we're partnering with the Tertiary Care Academic Medical Center, and our trainees partner with the Colombian trainees. And then the fifth site to mention, which is the one that I co-direct, is in Uganda, is in Kampala, which is the capital. And we work with Makerere University School of Medicine, which is the main public medical school in the country, and Mulago Hospital, which is the main public hospital. So they are not the same institution, but they have a relationship. They could not exist without each other. So I'm going to talk a little bit more about this model just to give you a sense of what we've been doing. So the Makerere University, Yale University collaboration, so we really started in 2002. And at the time, they only had general wards. There were no subspecialty fellowship programs in the country. Some folks might go to South Africa, some folks might go to the UK to get some additional training, but by and large, basically the generalists were functioning as specialists, and there wasn't formal training. It was more of an apprenticeship kind of a thing. Now that said, Makerere has a lot of international research collaborators. There are probably more than 30 European American universities that are engaged in research with them, and most of that research is focused on HIV and communicable diseases. So importantly, they had no collaboration that was focused on improving the care of the patients who were in the hospital that was across the street from the fancy, beautiful HIV research center. But those patients could not access the medications and the testing that was in that center. So the first thing to do is engage your stakeholders. So my colleague Majid Sadiq, who is the fourth one from the left, he was our Yale point person at the time, and he had gone to do some teaching around HIV care, and so he was talking with his Ugandan colleagues about this problem of having this wealth of research collaborations but nobody working on patient care. And so what they decided to do was come up with this partnership model. And at the same time, Yale was working through this funding that was helping us to develop more bidirectional partnerships. And so certainly Majid was looking for places for residents to be able to do rotations as well. So they developed MUU with the vision of creating a mutually beneficial relationship with the ultimate goal of improving the quality of patient care on the hospital wards. And the method, because as I said, this is what we do, is education, was to focus on education, feeling that patient care will improve as the human resources were strengthened. Okay, so I mentioned, we're sending residents, we're sending students, so let me tell you a little bit about the other pieces. So when we have our faculty and medical student development piece to our program, and this is a picture a couple years ago of me with some of the faculty who have come to Yale. So since 2006, we've had 29 faculty from Makerere who've come and spent 6 months to a year at Yale doing observership training, in particular subspecialties. And all of them are actually back in Uganda. All but 2 are working at the medical school teaching, and the 2 that are in private practice take students in their practices as well. So it's been really exciting for us, certainly when we send our trainees, for them to be able to work with Ugandan faculty who have been trained at Yale and can talk very fluently about the standards of care in both places. But also really exciting to see the amazing work that they have done going back to Uganda with these skills, and sometimes in partnership with their Yale mentors still. We also supported our colleagues on applying for a grant to actually develop an office to focus on postgraduate medical education, so a residency program, which they had not had before. And they are now in the 10th year basically saying, for our cardiologists in the room, just saying that we need to focus on rural healthcare as well. So thinking about this and thinking about what Linda had to say made us interested to see what we could do. So a little bit about Grundy County. So the first time I went, Emily Parton, our colleague, said you have to go on the Fiery Gizzard Trail and take a hike. It was amazing. It was beautiful. So Grundy County is this beautiful place. There is a long history of sort of thinking about social justice. The Highlander Folk School, which in the civil rights era was a major training program for nonviolent protests, is there. And this is Dr. Martin Luther King Jr. at the 25th anniversary of the Highlander Folk School. And this idea of community connection, community activism still goes on today. And this is a picture from a local Grundy County Health Council meeting. So there's a lot going on in Grundy. Population, 13,000. Median household income of $34,500, which is lower than the state mean. Life expectancy also lower than the state mean. And they were ranked 93rd out of 95 counties for this sort of composite health outcomes group. This was by the University of Wisconsin Population Health Institute. I should say they were 95th, so this was actually an advancement just last year. Okay. A little bit more background just to give you context. So in terms of, I compared them to Hamilton County because that's where we are. In terms of the number of doctors per 100,000 population, the WHO recommends 100 doctors per 100,000 population, right? So Hamilton County is doing great. Grundy County, not so great. This is actually one physician there. As far as APRNs, so similarly, Hamilton County is doing all right. Grundy County, much less. And there's a higher proportion of uninsured folks living under the age of 65. So the first step was to engage the stakeholders. So Emily, who is sort of the unofficial mayor of Grundy County, she's she's from there. She's just this amazing civil-minded woman who was our first connection. We met with some community physicians to talk about, what would it be like for our residents to work with them. The Beersheba Springs Medical Clinic, so Allison Gower, the executive director, is here in the audience today. South Cumberland Health Network, which is a multi-institutional sort of collaboration of folks who are interested in thinking about the health on the South Cumberland Plateau. The local health system, and then also Southern Health Partners in the Grundy County Jail. So these were the partners that we were talking with. So you might recognize this face. This is Dr. Nicholas Familia when he was an intern, fresh-faced. So our first step was to send a resident to test it out. So we had a 2-week tester when Nick went down, and he had an opportunity to rotate with all these different sites. Came back and said, this was great. So we sent him back. So last year, we were able to get funding for Nick to spend about 6 months working there as a chief resident. And he was there and he mentored 2 of our other residents who were there for 6 weeks at a time, and really helped to sort of build our collaboration. It was so key to have this gentleman with us. And then this year, now Nick's in Tennessee, and not only that, he brought his wife. Physicians. So now this year we've got 2 4-week-long resident rotations happening, and this developing collaboration with Erlanger and St. Thomas, which I'll tell you about in just a second. So just a word about the clinical site, the Beersheba Springs Medical Clinic. Beersheba Springs, population 459. It's a not-for-profit medical clinic founded in 2010 that offers free medical care. They have 3 paid staff, but the physicians are all volunteer. And I think this is so amazing, the fact that, although 32.5% of the population of Beersheba Springs is below the poverty line, more than 10% of the clinic income came from patient donations, right? So folks who are coming to a free clinic because they don't have another option, yet they're able to reach into their own pockets to donate to ensure that this continues. At the time, the clinic was open just on Mondays and Wednesdays, and they were averaging more than 2,000 visits a year. And importantly, although they were in Grundy, more than 17 counties have folks who have come to get care at this place, which just speaks to the lack of this kind of resource in other places. The rotation, so either 4 or 6 weeks. our folks come and they live and they work in Grundy. Most of the time is spent at Beersheba Spring Medical Clinic. They also rotate with local providers and the county jail. And then Emily has also gotten opportunities for our residents to go and speak with local elementary school students and to go to the Rotary Club and really to get a sense of the community in that way. We ask our residents to write reflections about the experience, and so just a little bit about what they said. I know that I saw injustice in the form of denial of access to health care. I saw extreme poverty. I also saw the same people served by the free clinic setting aside money to make a donation. But I think this is my last quote, but I think this is the most impactful for me. I am reminded of my goal at the beginning of the rotation to let go of unconscious biases I may have held about Appalachia. I spent a mere 6 weeks there and cannot possibly pretend to fully understand the details of people's lives, much less comment on their political inclinations or voting patterns. And I think in today's day and age, to have an experience in your medical training that can have you walk away with this kind of an impact, to me, is priceless. So now, as I mentioned, we are so fortunate to be collaborating here with Erlanger as well as in Nashville with the folks at St. Thomas. And together with Erlanger and St. Thomas supplying additional physicians such that the clinic can now be open a 3rd day a week on Fridays, we've been able to actually serve many more patients. So the rotation structure for this year, now that we've got the folks from Erlanger and St. Thomas, is such that residents can either opt into sort of more of a longitudinal experience, depending on which institution you're from, or more of a one-time, just sort of come up and work for a half day and see. The Erlanger and St. Thomas residents are only at the medical clinic. They're not rotating with the other providers in the community. And as I mentioned, the internal medicine attendings from Erlanger and St. Thomas are volunteering to precept residents and help the clinic to be open on Fridays. And then the Yale rotation is the same as it has been, with the benefit of being able to work now with the Erlanger and St. Thomas faculty. So, mutual benefits here. So now the clinic is open 3 days a week for the first time in its history. 50% increased capacity. And I think Allison photoshopped in that now Fridays 8 to 4 in the sign. Yep. This is a great opportunity for residents from Yale, Erlanger, and St. Thomas to collaborate. And we've been talking about, what kinds of educational materials for the clinic staff could be put into place, or educational materials for residents who are interested in going. What can they collaborate on to make this move forward? And for us, our residents now have an opportunity for exposure to rural health issues that they would not have had otherwise. So when I think about that same framework, the setting here is outpatient clinics. The immersive component for our residents is living in Grundy County. And then the capacity strengthening focus is that they are supporting efforts to improve patient access to care, helping to work during the days that the clinic's open. They're able to collaborate with the staff that are already working there on some continuing education. When I talked to Allison about the experience of having residents working with the current staff, there's a lot of sort of question-answer back and forth that's happening there, about the different diagnoses or management. And again, Yale trainees are part of a much larger endeavor. So while they might not make a lot of impact themselves on individual patients' lives for the long term, they are part of this collaboration that is growing and hopefully will be sustainable for the longer term. So in sum, while I would like to think that all 3 of these examples were nicely and neatly planned out from the beginning, they were not. They were very organic processes. And they've sort of had this similar approach, though, when we reflect on it. So one is sort of hearkening back to this definition of global health. So again, thinking about not geographic boundaries, but really thinking about the communities that you're serving. 2, focusing on this global health ethics framework, thinking about having humility and solidarity and being introspective and focusing on social justice in all 3 of these endeavors. And then lastly, this dual goal of providing resident education plus improving patient care and thinking about the health of the community. And this has allowed our residents to access some critical global health clinical education opportunities. So you can't do this alone. I actually have 2 slides worth of thank yous, but I'm just going to focus on this one and the Tennessee portion over here because it truly does take a village. And so specific people in the audience that I would like to thank. So Lou, certainly for your support, and Mike as well. Nick, for being the sort of fulcrum around which our Grundy County efforts have centered. And then Allison as well for welcoming us in. And with that, I'll say thank you, and I'd be happy to take any questions. Yes. Yes.
First, thank you so much for being here.
Sure.
It's a pleasure to meet you. What about surgical trainees and faculty who might be enormously interested in these opportunities?
Mm-hmm. Absolutely. So if folks didn't hear, so the question was, what about surgical trainees and who might be interested? So, so I've actually thought more about that in Uganda than I have necessarily here. I think, you know, the ethical issues with more of the procedural specialties are trickier, right? Because it, you know, supervision is different on the wards when, you know, the faculty have to have multiple jobs in Uganda in order to make ends meet. So they're not present in the same way that faculty are legally required to be present here. So when we have sent surgical trainees to Uganda, they usually go together with a faculty member. And then if that faculty isn't able to be there the whole time, they are sort of more closely tied to Ugandan faculty with sort of the expectation that there's going to be more supervision. So I think that's the one thing, is I think because you know, the ethics of having folks in procedural specialties can be a little bit trickier. We've focused more on trying to have tighter supervision. So I think that's one thing. Were you thinking specifically about Tennessee, or were you thinking about just in general? Yeah. Yeah. But thank you for the question.
I just wanted to say thank you again for coming, and I think this is one of the more important things that we're doing in the department. So I want to thank you for your mentorship with Nick and helping us sort of participate in this. I think this is great. I had to step out and take a phone call, so I apologize, but how many trainees from your international sites come and rotate in New Haven?
So, so for faculty, so initially when we started, the first year we brought a couple of residents from Uganda, and then based on other experiences that my colleagues had had, we realized that it's actually much more effective to focus on junior faculty because they have a job to go back to. And they also know specifically what they want to get out of the experience. So since 2006, we've brought 29 junior faculty. We've brought 2 nurses, a librarian, and then every year we bring between 3 and 4 medical students. But our medical school sort of says, you know, because our colleagues in Uganda host Yale medical students, they pay for the Ugandan medical students to come to Yale. They feel like that's the sort of the fair balance.
For example, the University of Miami, where I went to medical school, has a program where they bring people from South and Central America and either participate alongside the University of Miami students or actually do part of their residency at Miami. So it's just a different model.
Oh, that's fantastic.
I thought it was great because I had several of those colleagues.
Yeah. Well, certainly having the colleagues, when they are in New Haven, having our trainees in New Haven be able to have people on rounds who are thinking about with a different perspective. I mean, that truly, even for those folks who aren't able to take advantage of our program and leave the country during training, having folks on rounds with them is fantastic. You know, I think one thing, too, that has contributed to the numbers being what they are in terms of people that we bring is that the hardest piece is not necessarily finding the funding. The hardest piece is finding the right person to train. Because you want to make sure that they sort of know what they want to get out of the experience, that they have a plan for implementing it. Everyone worries about brain drain. We have been very fortunate in that all of our folks have gone back, and we attribute that to the fact that there is this tight connection. So even when they go back to Uganda, they still are being mentored by their colleagues at Yale. They still are working closely with us, and so we'd like to think that that helps to keep them working in their system. Yeah.
Thank you very much. It's inspiring. My question is in regards to the global and community health curriculum. Do you, are students and residents exposed to the principles of population health, public health, and epidemiology?
So that's a great question.
And do you partner with your School of Public Health?
So yes, so do we partner with the School of Public Health, and what about population health epidemiology? So we do also have pieces in our curriculum where we're talking about sort of epidemiology, biostatistics, and some of that is woven in there. I would say, as somebody who did a public health degree before I did a medical degree, that I wouldn't say that it's as integrated sort of fully as it could be. But I also think, because our residency program geographically was 40 minutes away for so many years, those of us on the core faculty are still sort of starting to get to know our colleagues in the public health school and think about how to bring them in. So that's something that's aspirational, but it's certainly something we're thinking about. Yeah.
Hi, I'm Holly. I'm one of the pharmacists here in Orlando. I work in the clinic in the transplant office. Part of my question is I do have an interest in pharmacy, integrating with physicians in clinic care. We do have several pharmacists now that are working in an indigent care clinic, internal medicine, and family practice. I was sitting here thinking that might be a huge benefit in rural health outreach as far as obtaining drugs. We work a lot with finding a cost-effective way to get medications to patients and optimization of dosing and regimens and things like that. Have you sought any collaborations with the pharmacy schools in Tennessee or in Massachusetts as far as helping with this?
That's a great question. I'm going to actually kick that over to Allison. I don't know if you have.
So we have a wonderful partnership with both AmeriCares and ANDA-Med. Last year we received something like, and we know the price is not really the price, but it was something like $768,000 in free medicine. So we do have a dispensary there, and we carry the most common things for hypertension, all kinds of stuff. We need insulin. We got a line on that.
Insulin is the worst, and I deal with transplant medicine. Insulin is my biggest headache. It's horrible.
Right.
But there are ways.
Right. Well, and we would be delighted to explore options that you might have. We also work some with GoodRx and some other things like that.
Yeah, you have to.
Yeah, and part of the thing that we're trying to figure out, this is a larger plateau issue. The St. Thomas Mobile Health Unit is coming up to Monteagle when they do their food banks. And part of the thing that they are trying to work out, and of course it's all connected to us, as kind of turning into a medical home for people who might go to the medical unit. But how do the people who go to the medical unit then get meds at reasonable rates? Because as Tracy talked about those choices that people are having to make, I mean, it is a question of do I eat or do I take my medicine, and especially with our diabetic patients, it's incredibly difficult to manage. So I would love to visit with you afterward, and we've got lots of surgeries we can do.
Thank you.